Hello, and welcome to the Duke Nephrology Conference. I'm Lynda Szczech, Associate Professor of Medicine at Duke University Medical Center, and since our last broadcast, have been proud to take over the office as President of the National Kidney Foundation. Today's program is titled Management of Diabetes in Patients with Abnormal Renal Function, and our distinguished guest is my longtime friend Diana McNeill, Professor of Medicine at Duke University Medical Center here in Durham, North Carolina. Diana, thank you so much for joining us.
Lynda, it's my pleasure.
So Diana, the reason that I asked you to speak about this topic is I think that there are so many new agents available for the treatment of diabetes, and many nephrologists are having a tough time keeping up with some of these medications. So I'd love for you to kind of run us through how to manage diabetes and then specifically focus on some of the medications and what we need to know about in someone with kidney disease.
I'd be pleased to do that, Lynda. You know, in our practice, when you talk to our patients with diabetes and you ask them what's the thing they are most worried about with regard to their diabetes, you may not be surprised if they don't talk about their blood sugars. They talk about the complications. And due to some very respected movies that have been on TV over the years detailing the poor outcome of patients with diabetes and renal function, I don't even mention the name of it anymore, our patients are very concerned about progressive renal disease. And so
I cried during that.
I know, me too. And I will tell you that it is a pleasure to discuss some of the implications of the new medications, and there's new ones coming out every single day for the management of particularly type 2 diabetes in patients with abnormal renal function. But let's go over what our learning objectives are going to be. We always need to have these when we have a conversation. First, I think it would be helpful to make sure that my understanding of abnormal renal function in patients with diabetes is the same as your understanding, since we share in the care of a lot of these patients. And as you've asked me to do, I do want to review many of the new medications that are being touted for management of type 2 diabetes. The number is up to 19 right now, and that does not include insulin. And then I want to talk about some of the ways the endocrinologists think about strategies for managing patients with abnormal renal function. And you'll be surprised that it isn't only about the blood glucose. But that being said, let's review the biggest problem. We have not cured diabetes yet. We just haven't. And unfortunately, as you are very well aware in your profession in nephrology, diabetes is the leading cause of kidney disease and end-stage kidney disease and dialysis. And I gathered these facts a couple weeks ago from the CDC, and we right now have about 18 million people with diagnosed diabetes. But the tricky thing is that if you take your eye to the top of the slide and see that they say that diabetes affects 25.8 million people, 18.8 and 25.8 aren't the same number. And so the difference there are all these people that are going undiagnosed for years and years and years. And as you know, and I think should be concerned about as a nephrologist, a lot of these people are younger. And so therefore, the longer they go without diagnosis, it will allow them sometime to have some of the complications that we worry about, including kidney disease. The other thing that I think is important for our listeners to be aware of is that we are very aggressive now about managing what we call pre-diabetes. And pre-diabetes is defined as a blood glucose now fasting between 100 and 125 and checked a couple times, or a hemoglobin A1C of 5.8 to 6.4. And so when you are seeing patients in clinic, and we'll go over some cases in a minute, Lynda, of patients who may have abnormal renal function, please, please, please think about diabetes as a possible cause. And we'll talk about some of the strategies for considering that. So you know I love patient care, and you do too, and so let's start with the patient. This is a 45-year-old male who came in with a 30-year history of type 1 diabetes. And I chose type 1 diabetes initially not because it's the most common type of diabetes, it isn't, but it is the one when you talk about renal disease that usually comes to the forefront of most healthcare providers' mind as being associated with renal disease. We're going to disprove that by the end of our conversation today. So as is not uncommon, the patient came in and said, I have frothy urine. Now, I always am perplexed when patients say they have frothy urine. I'm not sure what that means. You know, there is this history of diabetes where they said the original diagnosis of diabetes was made when someone drank urine and thought it tasted sweet. I never bring that up to patients because I think it's disgusting. But that being said, patients with diabetes are extraordinarily concerned when they perceive something's wrong with their either pattern of urination or their urine. And so he came in with that, and he also noted some dysuria, burning. His diabetes control was not optimal. I guess you would probably agree with me. I get comments from you about the need to improve the patient's diabetes control.
Easier said than done.
I'm glad you can say that. He was on a sort of standard intensive insulin therapy regimen. And in this case, I chose a patient who was on intensive insulin therapy because for many of us, when we're dealing with chronic kidney disease or any kind of problem with renal function and diabetes, the immediate response is to tighten up the glycemic control. I'm going to try to help you think that that's only part of the equation here. And you saw in this presentation that this patient's on 35 of glargine, and I'm going to start reminding people that that's the basal or background insulin. That matters when you have chronic kidney disease of any kind because that insulin will stay around for a long time. It's the capital G because it's the basal insulin. And then he was using 10 units before each meal of short-acting insulin. So he's in the clinic. I'm looking at him, and he's not caring about his blood sugars. He's caring about his frothy urine and dysuria. So the question comes up, what's next? And this leads us to some thoughts when you want to address this particular problem in patients with diabetes. And so first question is frequency of urination. In your case, you may ask me if the patient's urinating at all. For me, if the patient's got polyuria, sometimes that can reflect obviously urinary tract infection or poor diabetes control. And, we've had adult patients who come in and say they have incontinence of urine overnight. I saw a patient like that yesterday. Obviously, we care about hematuria. Most of us in our practices, Lynda, will dipstick the urine in clinic. And then fevers and chills. And, the obvious things that make one think that the patient has a urinary tract infection. So the first three things seem not that intuitive. But why do I have up there cardiovascular risk factors, retinopathy, and hypertension? Because you told me I need to think that way. Cardiovascular risk factors are intrinsically tied to diabetic nephropathy. A classic question that we usually ask a lot of our learners is, if you could check one lab to sort of predict what patient is going to have problems with heart disease, which lab would it be? And,
either creatinine or urine albumin excretion, depending on the study.
And it's not just the nephrologists who tell us this, but it's urine microalbumin a lot of times. And so for our patients with long-standing diabetes, and this man has had type 1 now for a while, the development of urine microalbumin can be a predictor of small vessel disease and cardiovascular implications. And so we care about that. Now, I wanted to ask you a question since I can get free consults from you sitting here right now. One of the things that we used to believe is that if you had retinopathy and nephropathy, defined as any abnormal protein excretion, then we as endocrinologists could be comfortable that the nephropathy was probably diabetes related. But if you had no retinopathy and protein excretion, that we needed to be looking for other causes. Help me. I've sent you consults on this in the past.
I think that that is probably a fair assessment in type 1.
Okay.
Because the type 1 folks, the studies are pretty suggestive that the two go hand in hand. With type 2 patients, I'm a bit worried about the assumption, not so much the assumption that if they don't have retinopathy, it's not diabetic nephropathy, but the assumption that if they do have diabetic nephropathy, it is, or diabetic retinopathy,
right.
They do have diabetic nephropathy. The reason is, back in the day, before ACE inhibitors and ARBs, when ACE inhibitors were the new kids on the block, you remember all the wonderful studies that compared ACE inhibitors to calcium channel blockers.
Right.
And I think that those youngins that are coming up through the ranks, they forget that we actually used verapamil and diltiazem before ACE inhibitors came in widespread use. Around that time, there was a biopsy series out of Italy that looked at consecutive biopsies of people with type 2 diabetes. Right. If you came in and you had type 2 diabetes, you got a kidney biopsy. Right. I don't know how they got that through the IRB, but 1/3 of them had lesions other than diabetic nephropathy, minimal change, amyloid, membranous, suggesting the fact that it's not as pure a lesion in type 2 diabetes, and that they are at increased risk to have other pathologic changes affect their kidney function. So I'm always wary of saying, well, it looks like a duct, so it must be a duct, in someone with type 2 because of this single study, and there have been others that have kind of suggested it.
Okay. So you are consistent, and in this particular situation, you know, obviously I would have less anxiety in this particular patient if he had retinopathy that any proteinuria would be from something other than diabetes. This is a common question patients ask us. Is this related to diabetes? And I think from a healthcare provider's perspective, I want to leave you with the information that you shouldn't always assume it's diabetes related, because the second thing that can be a leading cause of the nephropathy is poorly controlled hypertension, and it works as a continuum. If you look at this interesting diagram, and it was embarrassing to me, maybe initially, to make the blood pressure, which is the red gear, be the bigger gear compared to glucose, which is where I live, or protein. But truth be said, even endocrinologists now and the American Diabetes Association believe that if you are going to try to prevent diabetic nephropathy, that you have to optimize hypertension management, and the lower the better, as long as you can tolerate it. And we'll talk about some of the reasons and some of the data behind that initially. But it is an interplay of glucose control, blood pressure control, and actually assessment and interpretation of any protein excretion. I always tell patients, you know, your kidney, and this is where the endocrinologist and the nephrologist probably use a different description. Your kidney is like a filter, and when you've had diabetes for a long time, and the pathologic teaching is if you've had diabetes more than 10 years, type 1 or type 2, you probably have some changes in that filtering system. You know, the pathology is the Chemnitz-Steele-Wilson changes. But as the filter gets a little bit looser from either increased preload stress from hypertension or glycemic control that's not optimal, then you'll start leaking protein. And patients will then turn to me and say, well, can I fix it? And I said, many times you can, and we have evidence that we will discuss in a few seconds from the Diabetes Control and Complications trial in the United Kingdom's prospective diabetes study that actually tightening up glycemic control can reverse that loose filter, if you will. So that being said, what we want to think about are some of the considerations in this particular patient with type 1 diabetes about how to protect his kidney. You know, after you've ruled out a urinary tract infection, which I think is imperative, you do want to begin talking about glycemic control. And we have a number of studies, starting out with now the one that is becoming quite old. It was in the 1990s, the Diabetes Control and Complications trial. I happened to be sitting in Las Vegas at the American Diabetes Association meeting when they presented the data on this, Lynda, and it was amazing. They presented it at 7 a.m. in the morning in this city, and 3,000 people showed up. 3,000 people at 7 a.m. at a meeting in Las Vegas is a unique event, except when we believed that the information that was going to be shared would change the way we thought about management of diabetes. And as you recall, and this was subsequently supported in a subset analysis of patients with type 1 diabetes who were randomized to intensive insulin therapy, which at that point was either 4 shots a day or an insulin pump, versus routine insulin therapy, which at that time was things like twice a day, regular and MPH, or pre-mixed insulin. We actually showed a considered decrease in retinopathy. That was the most outstanding finding in this evaluation of patients over 4 to 5 years. But over the retrospective analysis of data over a longer period of time, there was some evidence that there was some renal protection in patients who had defined as tight glycemic control, which comes under some conversation, but right now would be a hemoglobin A1C of 7. And if you want to take it to a more physiologic perspective, there is data, and this is from a journal that I think you are familiar with, the Journal of American Society of Nephrology, that pancreas transplant patients actually can show an improvement in their renal function, defined as now glomerular filtration rate and decreased proteinuria with tighter diabetes control. So as I get ready to branch into some of the other things we need to do to try to protect this gentleman's renal function, I don't want us to forget, and nor will I forget, that it is important to improve diabetes control in all of this. And as you want me to talk about, we're going to have to be careful because the medications in type 2 that we use to improve renal control or diabetes control in renal patients are important to consider, but also the use of insulin in type 1 patients who have renal disease is important because renal patients tend to have more hypoglycemia because the insulin isn't cleared as readily. So the other consideration, and the one that I want to spend a few seconds on right now, is blood pressure control. You already shared with us your support, and I will agree with you totally about the use of angiotensin-converting enzyme inhibitors, or ACE inhibitors. I had a patient yesterday who I had to convince to go on a very small dose of lisinopril. She does not have microalbuminuria. She's had type 1 diabetes for 40 years. She's in her late 50s. But she says, you know, Dr. McNeill, I remember there was a whole bunch of studies on the use of some drug. Was it Capta something? I said, yeah, Captopril, that suggested that we could preserve our renal function. And she said, I remember hearing about that when I was younger and thinking, I hope I never have to use these drugs. I said, well, what changed was we now are in a preventive mode as opposed to you already have proteinuria and we've got to, stop it from getting worse. But another unexpected benefit, if you will, of the ACE inhibitors is that now we're starting to think that they're cardiac protective. We call that, in doctor terms, pleiotropic effects. Maybe they help in inflammation, and maybe they dilate in small vessels. And there are a number of studies, some of which I've listed up here, that suggest that ACE inhibitors may have both a renal and a cardiac protection, and that may be an additional reason for consideration of those medications. And then your group has had a very well-respected study, the Renal study, looking at the use of angiotensin receptor antagonists for patients that can't tolerate an ACE. And I finally put up there the classic study that I hope our listeners will use when they talk to their patients, called the HOPE trial, which looked at enalapril and showed a considered improvement in cardiac events and also renal preservation with a very low dose of enalapril over a long period of time. But here's my question again. You can send me the bill at the end for all these consults. Would you combine, as a nephrologist, if I asked you, we have a patient with on an ACE inhibitor and creatinine and GFR are still increasing, would you add an ARB, or is there any support for using combination therapy?
The trials there are really conflicting. They're small, they don't necessarily agree, and there's a lot of controversy there. The one thing that they do agree upon is that the person who's on combination therapy has a greater risk of adverse events. Hyperkalemia, acute renal failure, et cetera, et cetera. So there's a price. Not in all comers. I don't think there's a benefit. So what I tell people when I'm asked that question is that proteinuria is an intermediate outcome. It's an intermediate outcome to be respected. That if it's high, you have to get it low. And if you max out on an ACE, I tell people that I think the studies support, and this is interpretation, that adding an ARB on top and checking in 3 months if it further lowers the proteinuria or the microalbuminuria is an okay thing to do. And if it does lower it, it's probably okay to accept that risk. But if you don't see a decrement in proteinuria, then stop the ARB. And that's the one thing that I think that we have a tough time doing once we start stopping them.
Patients ask us to all the time, but we tend not to want to do that so regularly. So speaking of what Lynda was talking about with complications, the use of the ACE inhibitors is level C evidence, which isn't 100% perfect, but it's still good. But as you mentioned, we do want to pay attention to potassium and renal function. And then many patients will say that this is the major thing they're worried about, which is the about 15% on a good day incidence of this horrendous dry hacking cough, and we've had a lot of patients who presented to clinic with this chronic cough, and they get this intense workup, and then we forget to remind ourselves and maybe the patients that this is not that uncommon with an ACE inhibitor, and that's one of the reasons some of us convert to the ARB therapy. And then also, if we are managing patients in pregnancy, this is absolutely contraindicated. But going back to our patient, we want to try to optimize his blood pressure. Right now, our goal, and I said it earlier, is to try to keep it as low as possible. I want to put a plug in for type 1 diabetes having some complications with autonomic neuropathy. And so autonomic neuropathy becomes the bane of my existence in trying to manage blood pressure. And in English, that means that when the patient is supine, their blood pressure is quite elevated, but the minute they stand up, they are orthostatic. And that is a result of long-standing diabetes, Lynda, and one of the things that you can decide in clinic as a practical way to assess this is normally when your blood pressure falls, your pulse goes up, but when you have autonomic neuropathy and diabetes, which can limit the ability to control blood pressure, you don't see a pulse change. But that being said, the goal right now by the American Diabetes Association is less than 130/80. They still are advocating actively for something that our group here at Duke was one of many groups involved in, which is the sodium restriction diet and the DASH diet, the healthy diet. It's become very popular as we are trying to decrease the incidence of diabetes. And then, as I mentioned before, many of our patients will need not just a ACE, but may need 2 therapies, and we still consider the use of diuretics, remembering, and I again saw a patient recently who was on a thiazide diuretic with a creatinine of 4. It doesn't quite work so well at that level, and so sometimes they need a little bit of diuresis. And then again, going back to the excellent point you made, is that in that type 1 diabetes and type 2 diabetes are not exactly the same thing when you start developing nephropathy. And as you pointed out earlier, type 1 diabetes and hypertension and microalbuminuria usually reflects a complication of diabetes, while in type 2 diabetes, hypertension and microalbuminuria may reflect the metabolic syndrome or other causes, and that's an important take-home point from this case. There are definite benefits to good blood pressure control. We decrease the cardiovascular risk significantly. We decrease microvascular disease. And then the take-home message is that even what we would consider in our world a small decrease in systolic blood pressure decreases any complications of diabetes. And that's because of the microvascular disease by 12%. And so giving patients statistics sometimes isn't the best way to help them understand why they need to work on their blood pressure and diabetes, but just telling them that it does serve to hopefully decrease long-term complications is probably good information for the patient. So let's do a second patient. This is going back to our more common type of diabetes. This is a 50-year-old female with a 10-year history of type 2 diabetes. And she presents to clinic and is noted on routine urine microalbumin screen to have a value which in our world is elevated. And patients care. When we start sending them notes and say, you have protein in your urine, most patients who know how to spell diabetes realize that that's a warning sign. And so my question to our audience is, what do you tell her? So let's go over first what urine microalbumin means. So urine microalbumin is a measurement, and right now, at least based on information that your group has given us, most of us do what is called a spot urine microalbumin to creatinine ratio. I hope we don't have to do too many 24-hour urines anymore.
Never again.
Never again. Never again. And actually, that's an important take-home point for our listeners, I think. We don't do the 24-hour urines. But when you do the urine microalbumin, be cautious about the things listed on this slide, because this can cause you to have a positive urine microalbumin. I didn't say a false positive urine microalbumin. This will cause you to have a positive urine microalbumin. And I have been tricked more than once, particularly in my female patients when they've been on their menstrual period, and I forgot to ask them that for some reason. I get a urine, and I forgot to think about it maybe too, and it's positive for protein, and then I'm all excited, and they're all excited, and we have to recheck it. But the other things on this chart, including strenuous exercise, fever, heart failure, uncontrolled hypertension, uncontrolled hyperglycemia can cause microalbumin. And if you're going to use this as a risk stratifier for heart disease, you may want to check 2 to 3 specimens before you do that, because what patients are going to start seeing is what's on this chart here. At our institution, as you well know, now when you order a creatinine, under that they list the glomerular filtration rate, because your group told us that that's now an important way to assess renal function. So I'm doing the microalbumin, it's positive. Then I changed my view to the glomerular filtration rate and look to try to establish which stage of chronic kidney disease the patient is in. I don't know if you can explain to me why we started doing that. As opposed to just a straight creatinine. A patient asked me that yesterday. I said I was going to be talking to you and I would ask you directly.
So creatinine, of course, varies based on muscle mass. And I always use the example, a great teaching example, that when I was a fellow and I exercised because I had time, my creatinine was about 1, which would be uncommon in a woman.
Right.
Now my creatinine is 0.8 because I have a wonderful husband, 2 wonderful children, a fabulous dog, a career that I love, and I haven't seen the inside of a gym, and I'm not going to tell you how long. So my kidney function hasn't improved, but my creatinine has gone down because my muscle mass has shrunk.
Okay.
So just doing creatinine gives you that extra variable of what does this number mean in this person.
Right.
So converting it to creatinine clearance is helpful, but that formula is not so good in terms of the variability. GFR, CKD epi formula is best. The MDRD formula is far better than Tarkov Gulf.
And all of those formulas can be found online and can be found with on Google or any other resource that you might want to use. But when this patient came in, we looked at her urine microalbumin, and then I looked at her GFR, and her glomerular filtration rate was normal. And so I was less anxious than if I had another patient whose GFR was 30, which would reflect severely decreased function in a stage 3 chronic kidney disease. So from an endocrine perspective, and hopefully from a healthcare provider's perspective, when you start seeing a drop in the glomerular filtration rate, that's more of a warning sign sometimes that you need to be more aggressive in your hypertension management and more aggressive perhaps in your diabetes management than if you just see a change in creatinine. And I don't ignore a change in creatinine. Please don't misunderstand me, but nonetheless, I think in this particular patient, we're going to want to, A, make sure the microalbumin is correct, and B, assess her glomerular filtration rate. So now let's go to what you want me to talk about in particular for our listeners with regard to the new medications that are available for management of patients with diabetes. So this is a 67-year-old male, 18 years of type 2 diabetes, and I always want to point out that type 2 diabetes, the diagnosis, often reflects the fact that it was existing for up to 5 to 10 years prior to diagnosis. You know, we often don't call it newly diagnosed diabetes, we call it newly recognized diabetes. And the reason that's important is that when you see the creatinine of 1.4 and the urine protein of 1+, this may reflect a very long period of diabetes, and his hemoglobin A1C is not at goal. Again, right now the goal is 7. We aren't pushing it towards 6.5, and I just wanted to remind our listeners that an 8.3 hemoglobin A1C reflects an average blood sugar somewhere around 200, and we obviously would want to improve that. Now, the one caveat that came out in 2010, Lynda, is that the use of the hemoglobin A1C for older patients needs to be lifted up a bit, and so we are now told that in our geriatric, defined as 80-year-old population, that a goal hemoglobin A1C could be up to 8, and that is because of the concern regarding hypoglycemia. Now, here are some blood sugars. Look at them, and you can see they're all high. That's the point of this. They're all high. And in this particular patient, when you see uniformly high blood sugars, and this patient is on, as you can see here, Lantus insulin, 12 units here, and this is a series of increases that we contributed to in advising the patient to try to get the blood glucose better. We didn't do a very good job. They're still in the 200s. So in a patient who has abnormal renal function, and this patient had a creatinine of 1.4, GFR, which was not totally normal, I would have not a lot of anxiety about making some appropriate increases in the long-acting insulin. And then I would query whether or not the shorter-acting pre-meal insulin, which in this case was a Novolog, could also be increased. So a couple teaching points on just how to analyze the blood sugars. When you look at a pattern, and that's the key word, pattern, you want to look at the total daily dose of insulin. So what happens a lot of times in patients with renal disease or not is that people like me or even patients or you look at what they got in this top line and not what they got in the bottom line, which is the correction insulin. So pearl number 1, add it all up and then make an increase. This increase here, it obviously didn't work because if you look what they did here, they went from 12 to 15 of Lantus. The patient already got an extra 3 units here, and it didn't even touch their blood sugars. They're still in the 200s. So what you would have done is added all of this up and probably increased this somewhere closer to 20 units to start with and tried to see if you saw an improvement. When I have a patient who has chronic kidney disease, I want to be conscious about the different kinds of insulin and their time in a patient with renal disease. As we see patients progress towards stage 5 chronic kidney disease, we see the onset of actions of all of these insulins lengthen. They lengthen. And they lengthen in part because, as I alluded to earlier, insulin is partially renally excreted. And so you'll see patients, and it's scary to people like me, who have been on 4 shots a day forever, sometimes be able to be managed with a little bit of glargine and occasional short-acting insulin based on carbohydrate counting before meals, where before they were on 50 units or 60 units. The second thing you need to be aware of if you're going to use insulin in your patients with type 2 diabetes or type 1 is that as the kidney starts to fail, we call it glucose substrate decreases. And so patients with progressive chronic kidney disease are at extraordinary high risk for hypoglycemia. And one of the mistakes I would say we all make in management of these patients or don't think about down regulating their insulin dose as their renal failure progresses. And these patients can have severe life-threatening hypoglycemia. I put these different insulins up here mostly because for many of us right now, we still like the very short-acting insulin, Lispro, Aspart, or glulisine for meal use. And then many of us will use a lower dose of either glargine. Or in patients with chronic kidney disease, stage 3, 4, and 5, we can sometimes get away with a single dose of detamir, which even though it says it has a 12-hour half-life, in a patient with chronic kidney disease may actually ask for 24 hours. So pearl from this slide. The onset of action that we teach you for routine management in people with normal renal function should be extended. And number 2, be very vigilant for hypoglycemia. Now, when you look at this picture here, this actually is a cartoon that helps you understand why we worry about it in patients with renal disease. Just you need to know your insulins. Now, one of the things that people ask us a lot of times, including the nephrologist, is how do you start on your insulin? And I was giving a conversation recently to some emergency medicine residents, Lynda, on how to calculate insulin. And you can see on this slide that I've highlighted the word renal failure. And it is on the same line as new to insulin. So if you are starting a patient on insulin, remembering what I just told you, you need to start at the lowest calculable dose for their weight. And many of us will start somewhere between 0.1 and 0.3 units per kilogram in patients who have chronic kidney disease, stage 3, 4, and 5. That is 0.1 to 0.3 units per kilogram, total daily dose. And then what many of us will do is take that total daily dose and split it into half of the long-acting insulin or basal, and then split the remainder based on what they eat. So speaking of what they eat, our patients' diet usually is the bane of our existence when we're trying to deal with diabetes, but not in renal disease. People with uremia lose their appetite. They develop nausea. It is a problem I know you're very aware of, but as an endocrinologist or a primary healthcare provider trying to dose insulin in particular for patients with chronic kidney disease, please be vigilant, please, about what they're eating or not eating, because otherwise you're going to not match their insulin correctly to what they're trying to put in their mouth. So an example would be this person weighs 85 kilograms, you do 0.3 units per kilogram, that would be on the upper limits of normal for someone with chronic kidney disease, and then you give half basal and half bolus. make sure the patient is eating.
And that's real weight, not lean body mass.
That's real weight. Real weight. Good point. That is an excellent point. And that's one of the tricky problems that we have as people progress toward end-stage renal disease or chronic kidney disease stage 5, is that they often have a fair amount of fluid retention. So we changed the outpatient regimen, and I'm getting ready to go into at the end of our conversation here, some of the new medicines, when things change. And on the different insulin pharmacokinetics, besides ascites and heart failure, is renal failure. When nutrition changes or when we add different medications. So let's talk about the new drugs. If I was standing up and not sitting here, I often do the Macarena dance when I try to talk about these drugs, because when you try to learn about all of the new drugs listed on this picture for management of type 2 diabetes, and let's be clear about this, this is type 2 diabetes. Type 1 diabetes, we're doing most always insulin. These drugs affect different parts of the body, and as I talk about them, I'll mention what some of the considerations are for patients with renal disease. We'll start with the fact that all of these are to try to reduce hyperglycemia. And the big number one drug we use, and this has been supported in a systematic review last week in the Annals of Internal Medicine, is metformin. And the common question, I get asked this all the time, is how bad does your renal function need to be before you have to stop the metformin? Well, the teaching still, if you pull up the literature in the package insert on metformin, is a creatinine of 1.3 for men and 1.4 for women. But remember what you just taught me. We aren't always using creatinine as a measure of renal function. So I would say, and we have certainly done this in our practices, if you've got someone whose creatinine is 1.7, 1.6, and their muscle mass reflects that, then we have left people on metformin. Reminding you from the diagram that metformin works at two spots. It works at the liver to decrease hepatic glucose production. And then the reason we like the drug is it works at the muscle to decrease peripheral insulin resistance. It is the first line drug for type 2 diabetes. So for many of our patients with chronic kidney disease stage 1 and 2, metformin should be the first line of medication. Now, in the same article, Lynda, they talked about what do you add. And this is where we get into some professional decision making. We have a couple other choices, and these we have even more than are actually on the slide here. We have the glitazones. Right now, only one that most of us would use, which is pioglitazone. And we have the sulfonylureas. And then we also have now a whole group of medication called the glucagon-like peptide 1 medicines that actually work at the gut. And most of us now would think about using as a second-line drug in someone who had relatively early recognized type 2 diabetes, either a glitazone or a GLP-1 glucagon-like peptide drug for the following reasons. The glucagon-like peptide drugs include exenatide and sitagliptin and liraglutide. And those drugs work to decrease glucose reabsorption from the gut. They also help stimulate a little bit of insulin secretion from the pancreas, and they also make you feel full, and particularly exenatide. They do need to be dosed, particularly sitagliptin, for renal disease. And in fact, I do not use them in stage 4 or stage 5 chronic kidney disease because of the considered risk of hypoglycemia as one of the major side effects, and also nausea. Those are the two major side effects of those groups of drugs to start with. So in stage 1 or stage 2 chronic kidney disease, those are certainly available medications, but maybe not so much for the later stages. The glitazones offer a unique opportunity and a disadvantage. The glitazones tend to cause peripheral edema. And in someone whose chronic kidney disease is progressing, that would not be a good choice. So the glitazones are insulin sensitizers. We still use them. They still are used regularly, but we are cautious about their use in renal disease. Now let's go back to the grandpa of all medications, which are the sulfonylureas. You know, because you've heard us talk about this, that in patients who have progressive renal disease, we are particularly cautious about the use of sulfonylureas. And the reason is because of hypoglycemia. Many of the sulfonylureas have predominantly hepatic metabolism but may have a renal excretion product. But even without having a renal excretion product, because they work at the pancreas to stimulate insulin secretion, and even without renal disease can cause hypoglycemia. If you add renal disease with your decreased glucose substrate and also your decreased appetite, you may increase the risk of hypoglycemia. So, in summary, yes, you can use this in renal disease. I would use this in stage 1, 2, or 3. Yes, 1, 2. Pioglitazone, be a little bit more cautious about using that because of the associated edema. Prandin and Starlix are very similar in activity to the sulfonylurea, so we're a little bit cautious about using that. These drugs, most of us don't use. These decreased glucose reabsorption from the gut. They're excellent to use in patients who have reactive hypoglycemia, but I don't think this will be an issue for patients with renal disease. These are our newer drugs that work at the small intestine to decrease glucose from the reuptake from the gut, and you have to be careful about using them in renal disease, but certainly not contraindicated in stage 1 or potentially stage 2. And to be honest, bromocriptine came out last week. I haven't had experience with it. It's just been FDA approved last week, and I think the jury's still out on whether or not that should be used in renal disease. Finally, a couple special considerations. Dialysis. We have a lot of problems, Lynda, as you know, because you take care of them with us, when our patients are eventually on dialysis with their diabetes control. Part of that is because insulin hangs around for a while and then they undergo dialysis, and we're not 100% sure of the what happens to the insulin with dialysis, and it seems to vary from patient to patient. We tend to try to use a little bit of a long-acting insulin and then some short-acting insulin to match their food. We talked about nutrition earlier, but I want to put a little shout out for remembering in your patients who are losing a lot of protein in their urine that you got to be thinking about their nutrition, because their albumin can go down to 2 or 1.5, and we don't do so well managing their diabetes when they're malnourished. They don't absorb their insulin correctly. We have many issues. I put vascular access up here because in my clinic, after you all get the vascular access in for diabetes management or for renal replacement therapy, the diabetes management can sometimes be varied, and I'll tell you why. These accesses sometimes get infected. They sometimes are being used very successfully. So if you are a primary care healthcare provider taking care of patients who have either a real vascular access or a temporary vascular access, pay attention to some of the nuances of that. Pregnancy requires your help. If you have someone with nephropathy and who wishes to get pregnant, I will tell you at Duke we proudly have had a renal transplant patient or two have a baby. I think the old days they said it was absolutely contraindicated, but in the new days not so much. It just requires teamwork. And then finally, in my world, renal transplant is sort of the gift we can sometimes give patients to help them not have to deal not with both their diabetes as a chronic disease, but also their renal failure as a chronic disease. But that does not happen to all folks, and that brings up a unique series of problems. So lastly, I wanted to share with our audience a quote that I received about 2 weeks ago. Lynda, one of my patients who I've taken care of for my entire practice here at Duke finally got a renal transplant. He has been on dialysis for the last 2 years. He is a type 1 patient and he has been trying very hard to manage his diabetes. He's an avid bowler. He has had a good spirit. I went by to see him on the ward, and he told me something that really stayed with me for a while. He said, Dr. McNeill, thank you for keeping me alive with my diabetes for the past 20 years so I could get my kidney transplant. I have a new lease on life, and I feel so much better. I must have something I still have to do on this earth. I think I don't always realize, and maybe our listeners don't always realize, that particularly for patients with diabetes, since we haven't been able, Lynda, to cure the disease, it's going to be important that we manage the complications. And I want to personally thank you for your help in helping me manage the complications of diabetic nephropathy in patients with diabetes.
You're so kind. The pressure, the emotional pressure that our patients feel, worrying about their blood sugars every day, worrying about going to dialysis every day, really affects their quality of life. And I think that's what he told you.
Yeah.
So thank you so much.
Well, it's my pleasure.
You taught me so much.
Thank
I
you.
now feel like I'm going to be able to pass my boards next
Okay, well,
time
that's
they
good.
come
That's
up.
good. And thank you for the free consults. I appreciated them.
Oh, it's been my absolute pleasure now and for the next 20 or 30 years.
Good.
So again, I want to thank to you all, our guest faculty, Diana McNeill, for really helping to clarify some of the issues that I was hoping she would bring to the table. Until next time, then, from all of us here at Duke, my name is Lynda Szczech, and I'd like to say thank you for joining us, and please take care.